Thank you, Robin, for the introduction, and we're really excited to be here opening the 2020 series in Minds Behind the Mind. And and we would like to start by saying that we don't have any conflicts of interest in this presentation. And so before we talk about conventional and complementary and alternative treatments, we would like to review the background of GI symptoms in autism spectrum disorder and review what type of symptoms are more commonly found in this population and the type of workup that we usually order for this type of concerns. So the notion of GI symptoms in individuals with autism is not new. In his seminal article, Autistic Disturbances of Affective Contact, Leo Carney in 1943 described common features of 11 children with limited social interaction and communication issues, and they also presented with some GI issues. As you all know, the criteria for autism spectrum disorder has greatly changed over time since the first description. And based on the most current classification, we consider autism as a spectrum where people meeting the diagnosis presents with deficits in social interaction and some repetitive and restricted interests and sensory issues. I want you to keep that in mind when we talk about GI symptoms, because that is going to be also really helpful. And as you may know, many children with autism may also present with co-occurring conditions, mental health conditions, and also medical coexisting conditions. Unfortunately, many of those conditions may get unrecognized and untreated. But as I said before, today we'll be specifically talking about GI symptoms. And it is important to clarify that GI symptoms may be associated with the diagnosis of autism, but not all children with autism present with GI symptoms. The prevalence of GI symptoms in individuals with autism has not been clearly established. And as you can imagine, some clinical manifestations of the GI diseases may be very difficult to assess and may also differ in presentation in children and adolescents on the spectrum. Some of those issues may be influenced by sensory sensitivities, by high pain tolerance, by difficulties with communication, verbal communication and non-verbal communication as well. So it really needs a really high level of suspicion to make sure that we understand what is going on with the affected child. When we look at the prevalence of GI disturbances, it's not really clear. We have a really big discrepancy. So some studies have actually endorsed 9% of the prevalence. Some other studies, almost all participants, around 90% of the participants had endorsed any type of GI symptoms. And it gets a little bit tricky when you kind of take a look at the current literature, because there's many different methodological differences in those studies that make very difficult to come out with conclusions. So for example, there is a lot of selection issues. So there is even some studies when they don't have any clear classification for autism, or they may have a control group, but some other studies do not. They may also have different data collections. So some of them, they just collect the data through medical records, which also has its own issues, and some others just by parent interview. So it's just very difficult to translate and just to come out with a real prevalence. We have two systematic reviews that have attempted to analyze the frequency of GI symptoms in people with autism. And those studies actually compare this group with typically developing children. In 2014, there was a systematic review when they analyzed 15 studies that included more than 2,000 participants. And the authors reported that the children with autism, they have elevated odds ratio for GI symptoms. What that means is that children with autism are 4.4 times more likely to present any GI symptoms. Or they're also 3.63 times more likely to present diarrhea and 2.45 more times likely to present abdominal pain when compared with typically developing children. Most recently, in 2018, we have another systematic review, and they analyzed articles going all the way back to 1980. And what they found is that, almost every symptom that they analyzed was increased. The most common symptoms that both of these studies found was constipation, diarrhea, and abdominal pain. However, they also concluded that methodological issues, like just the one that I just referred to you, the lack of the definition for GI symptoms, what do we mean when we say constipation or diarrhea? And also the lack of a standardized questionnaire that has been developed only for this type of population. So there is consensus about the importance of GI symptoms. We know that children with autism that experience GI symptoms may present with, of course, impacted well-being, but they also may present with behavioral issues and just the whole health status and daily activities may be impacted. There is enough data suggesting that the brain and the intestine communicate with each other in a bidirectional manner so you have the central nervous system, and then you also have your gut. So we have this brain-gut axis that they actually communicate quite well. So you have some afferent, so just signals that go from the gut to the brain, and then some signals that also come from the brain to the gut, not only to regulate appetite, but also to regulate emotions and even learning and behavior. That's the reason why many people experience butterfly when they're in love, or they have abdominal pain when they have anxiety, because this connection and communication. And there's different ways that they communicate. So they make signals, and those signals can be done by neurotransmitters of substances that tells the brain how the gut is feeling, and vice versa, and also cytokines and hormones as well. So there is a really great communication between the two parts. So when we take a look at the enteric mucosa, the mucosa is actually really rich, in connections, neuronal connections. So there is hundreds of neuronal connections getting all these stimuli from the intestine to the brain. The intestine also makes more than 20 hormones to communicate with the brain, and it's 70 to 80% of our immune system. So it's quite important, right? And that's the reason why the brain, what I wanted to show you is, I hope I do it right. So this is the lymphatic system that is very important in the enteric mucosa. And then, but if you take a look at it, we also, the mucosa has a lot of interaction with the food, with antigens, and also with the microbiota. So what that means is that the intestine needs to realize what type of signals are danger and non-danger. We have a lot of exposure through the intestine to antigens and to just foreign particles that the brain needs, the gut needs to make the decision if it needs to make an immune response to it. So the pathophysiology of GI symptoms in autism is not fully understood. But I would like to present the current theories in a classification in three different areas. So the first one says that basically is postulating that the GI symptoms are exclusive to autism, and there is a common pathway that is affecting the GI symptoms on autism. The second group of theories is that there is the GI symptoms are causing autism spectrum disorder. I want to clarify that those two theories are basically not proven. We don't have enough evidence to say that there is an inflammatory pathway that is causing autism spectrum disorder, or that there is an immune response that is causing autism spectrum disorder. What we have more evidence is that there might be some genetic makeup, like some some alleles like the MET or some receptors that may change, or chromatin remodeling factors like the CHD8 that may D8 that may cause that some people that may present these findings, the genomics findings, may present with more GI symptoms and some other medical co-occurring conditions. The group of theories that is more accepted right now is that the symptoms of the GI symptoms are more related to the core symptoms of autism spectrum disorder, like insistence of sameness, wanting to eat the same food that may be causing some secondary GI issues, or the sensory issues that as well that might be related. So there are many reasons why gastrointestinal symptoms are important, and I want you to think about it. If the prevalence is right, I mean, with all the flaws that we have in the methodological issues that we have, it's quite important. And then if we kind of reflect on the core symptoms of autism spectrum disorder, many of those children may have difficulty communicating pain, or actually processing pain and making sure that they get the treatment that they need. According to the most recent recommendations, children with autism spectrum disorder, there are risks of having alimentary tract disorders, and just general concerns, as I said before, like constipation and abdominal pain and then diarrhea. So let's read this case. Steven is a 5-year-old boy with autism. He's nonverbal, and he has a history of repetitive and mildly self-injurious behaviors. 3 days ago, he presented with aggression that frequently ended in self-injurious behaviors, along with frequent night awakening, and all those behaviors are new. So as you all know, behavioral changes or worsening behaviors may have many different causes. So it can be changes in the environment, as Petrina just said it. It can be the person is not feeling well because medical conditions. Remember, we're talking about GI, so Steven have constipation and abdominal pain. That is very important to see that is like, it can be a psychological state, it can be a sensory issue, it can be just the difficulty communicating with other people, but it can also be medical conditions. And as I said before, unfortunately, medical conditions are not really well addressed all the time, and we need to keep that in the back of our minds, that children may present with increased self-injurious behavior, increase of repetitive behaviors, may just experience more behaviors that are undesired, vocal tics, or any other repetitive behaviors, and as I said before, self-injurious behaviors. So we need to be aware of these behavioral changes that may actually tell us that there is something else going on. Loss of skills is also a good one, and sometimes that might happen. But it has been studied that children with autism may communicate abdominal discomfort with different type of behaviors. Some of them are repetitive behaviors, including repetitive behaviors, vocal or facial expressions. And as you can read in the slide, those presentations are not typical for the typically developing children, like facial grimacing or teeth grinding, but it's our job to kind of analyze and making sure that what is going on. Another one can be motor repetitive behaviors, especially pressing the area when they feel discomfort or pain. And this is when the behavioral interventions and the biomedical model come together. Because as you know, functional behavioral assessment are really good trying to detect what type of behaviors or antecedents are happening with the behavior, but we need to keep in mind medical conditions as well, right? Because that can be a trigger for a repetitive behavior, some other behaviors that we want to extinguish. And then, so these abdominal behaviors, we need to keep that in mind. And many times the behavioral interventions can be focused, and the child can be taught about how to communicate that he or she has discomfort, and maybe having some other soothing techniques or other things that the child can do when they have a pain. So for example, I had a patient, a couple of years ago, and he has a GERD, so he had a really bad reflux. And then so every time they had reflux, he started presenting with repetitive behaviors like tapping on his chest, and we were actually very concerned that he was going to cause self-injury. But he was taught to use visuals to say, you know, I'm feeling discomfort and also looking for water. So some other ways to communicate, you know, I'm having these symptoms, I need some help from you. And there is enough literature supporting the idea of that GI symptoms may present with behavioral expressions, including, as I said before, new or worsening behaviors, including sleep problems and challenging behaviors. Sleep problems are actually being associated in multiple studies. It can be difficulty falling asleep. It can also be nighttime awakening. So it may present in a different ways, and that's something that we need to be aware of, and it's also part of the treatment as well. They may also present with more self-injurious and just more tantrums. They may be more oppositional and more reactive to changes or just to daily activities because they're not feeling well, right? Sometimes they may also present with social withdrawal. And despite all the things that I mentioned before about the prevalence and some facts that we are not clear, like the pathophysiology, we have consensus that these consensus that are very important, and I want you to just to take a look at it. The first one is that individuals with autism who present with GI symptoms warrant the same evaluation as those without autism. And this is due because we don't have any specific information that link GI symptoms with autism. So those children deserve the same treatment that typically developing children. So it is not acceptable to think that someone is presenting GI symptoms just because of the fact that the person has a diagnosis of autism. Common conditions are also common in individuals with autism, like for example, constipation, right? Or reflux. Those are conditions that are pretty common in children, and they are pretty common also in children with autism spectrum disorder. We also need to take a history. So the history should include developmental history, behaviors, when did behavior start, what type of behaviors the child is presenting, and then also any medications. You know that some medications may cause constipation, and some medications may cause stomach upset, or some other medical conditions that may be affecting the presentation of that particular child. So we also, as I said before, we need to keep in mind that for a person with autism, a problem behavior may be just the sign that there is a GI issue going on. Parents are experts, and we know that. So if there is a change in the behavior that the parents is noticing, probably they know that there is something wrong. They will not be the first person to detect that, and physicians should listen to parents because they know best. And then it's very important to assess the nutritional and growth impact. So if a child is not growing well, or if a child is having losing weight, that might be one of the symptoms that requires more attention, right, and more workup. So individuals with autism and coexisting GI symptoms are at risk for problem behaviors, as we said before. And there is a subgroup of children that may respond to dietary interventions. So we have then some literature where they found some benefit of dietary modifications and restrictions, but we're going back to the methodology. So just coming up with answers and conclusions is very difficult. Sometimes they don't have a control study, and it's just very complicated to come up with recommendations. But as I said before, parents knows best. So if the parent knows that when the child drinks milk or eat certain type of food, the child is becoming with more repetitive behaviors or self-aggression, we need to listen to that. And maybe it's worth it to have a trial, and sometimes if the behavior improves, maybe we might need to do, in some cases, we might need to do a further workup just to make sure that we, when necessary, that we clarify the diagnosis. A direct cause and effect of immunological issues has been reported but not proven. So we know that microbiota is very important in many functions, in immunological functions, in digestion, communicating with the brain, but we don't really know all the aspects about it. So this is an area when there is more growing research, so we don't have any specific findings on autism spectrum disorder. The evidence is growing, but according to the consensus, there is no association with that or with immunological issues. So with the workup, so as I said before, when a child we're suspecting GI symptoms, a child or adolescent, they were basically are following the same recommendations that typically develop in children. So there is no different treatment for children with autism spectrum disorder. We try to identify not only the severity, but also the location of the pain or the discomfort, just to make sure that we understand if we need to do any further workup, or we need to refer this child for a specialized evaluation. In the left side, you can find some symptoms like dysphagia, nausea, and on the right side, you can find some of the diagnoses that are commonly also mentioned in autism and GI literature. And many times when we try to explore the symptoms of gastrointestinal symptoms, we try to localize by upper and lower GI, because that helps us to realize like what is the cause of the pain or the discomfort or the symptom that the child is presenting. Sometimes the treatment, and sometimes need for evaluation or any other specialized workup. There is some alarm symptoms that we need to be with a medical history. We need to make sure that we're aware of. And as I said before, if the child is losing weight, if the child is not growing as he was growing before, so this acceleration in the growth. If the child is presenting with significant vomiting, a recurrent vomiting, if it is having a chronic and severe diarrhea that is being persistent, abdominal pain, especially those that are located in the right quadrant, it can be in the upper or lower. And any family history as well is very important, because if there is a family history of inflammatory bowel conditions, so we might be more alert that there might be something else going on. And any abnormal findings in the physical evaluation. So as I said before, we look for the medical, so we ask a lot of questions about the medical history, but also the physical examination. So when we do the physical examination, we don't only look at the abdomen. I mean, we look for distension, for masses, we look at the organs, but we also need to look at the perianal area and to see where the anus is located, if the anus has a good reflex or no. Sometimes we need to do rectal examination that may be challenging for some children. And we also have to do a complete neurological examination, because if someone, for example, has findings in the spine that may have a spina bifida or may have some neurological conditions, that might be affecting the GI instead of necessarily being related to some other causes. So the physical examination basically is a complete physical exam, just to make sure that we also rule out any systemic conditions. We usually try to avoid any type of workup that requires anesthesia, or any workup that that are more aggressive, that require procedures, because everything has a risk, right? So we just, as I said before, it's just physical examination and how the child is growing, and sometimes with some changes in the diet or some other studies that may be not as aggressive, like for example, blood tests that can tell us many things. For example, if the child has anemia, or if the that just the kidneys and the liver function. Sometimes we check also for lead levels as well. Sometimes the radiographic studies are really helpful, especially when we're considering maybe constipation, because we can see the mass that is located in the rectum, that it may tell us that there is some chronic constipation going on and that this child needs some other, the treatment that is for that. So some other studies, like functional studies and colonoscopy and endoscopy, sometimes they're needed, but those are not routine if a child is not presenting with any of the alarm symptoms that I just mentioned to you. So in 2010, a group of interdisciplinary panel of experts review the evidence, and then they come out with some recommendations for evaluation and treatment of children with autism and GI symptoms. When you take a look at it, there is not many changes with typically developing children. It's about the same, right? So if someone is having a constipation, you need to do a clean out, and you need to make sure that you use the laxative treatment for a few weeks, and then you make some dietary modifications and making sure that the child is eating fiber and enough fluids. So the changes are not really different to typically developing children, as I said before. And if you take a look at it, most of the time the first step is just to treat, like if the child is having symptoms of reflux, you just treat with a proton pump inhibitor and see how the child is doing clinically, just avoiding any type of extensive workup that might be not necessary and may put the child in a risk. And as I said before, sometimes when children have, for example, general symptoms, and we're not really clear what is going on, it's not clear if the child is having constipation or is having any other issue, we might need to jump to request some radiographs and some other studies just to make sure that we're not missing anything. So as you can imagine, constipation has many causes, and constipation is a really common problem in pediatrics. Based on the evidence we have, it seems like constipation is even more common in autistic individuals, right? But unfortunately, this may become a chronic issue. And then so you can imagine if you have constipations, now you're going to start presenting with some other symptoms like abdominal distension, changes in your appetite, you may have abdominal pain. You may also have actually issues with toilet training. So if a child is trying to learn, it's going to be more difficult. And some other children that are being toilet training now, they may start having accidents and issues with that. And if you think about it, and going back to the diagnostic criteria, if we think about the sensory issues, some children may have restrictive diets. Some of them prefer diets that are very rich in carbohydrates and may have low fiber and may be not really healthy choices. And those type of food are going to take more time to transit the GI symptom, the GI system, and then it's just going to prone them to have more constipation. And sometimes what is really interesting is that sometimes the constipation might not be really evident for anyone, not for the parents, not for the clinician, because if you have so much constipation, sometimes you may present with something that we call it encopresis, which is like basically the stool is leaking through the walls, and then you may have soil underwear, you may have accidents, and people may think that the child is presenting with diarrhea, and sometimes it's the opposite. The child has so much constipation that it's just the bowel movements are very difficult to control. So the constipation treatment usually require a multimodal treatment. So we need the medical piece, but we also need the diet piece, and we need the behavioral piece as well. And and then the behavioral changes are very focused on diet as well. So when we talk about the chronic constipation, we need to talk about bowel retraining, which is the first step is disimpacting the rectum, because sometimes there is so much stool that's the first step. And then sometimes we need to use this laxative treatment for weeks just to make sure that the digestive system go back to normality. And then, as I said before, the dietary modifications and gradual training. So in this image, this illustrate how. What do I mean? What do we mean with bowel retraining? So on the left side, you can see a rectum that is of someone that has presented with chronic constipation. So I want you to take a look at the wall. So you see the wall. You see the muscle is very distended. When the muscle is so distended, the nervous system, the nervous terminal, they just lose the capacity to be able to detect that there is stool in the rectum, right? And then they need to use the restroom. And then the rectum just continue absorbing water, so the stool becomes really hard and dehydrated. And then, so as you can see, there's just small balls, and sometimes just to clean out this rectum and retraining is gonna take weeks and sometimes several months. So at this point, many children, they just refuse to go to the restroom. It's just too painful. And sometimes what happens, what I mentioned before, you can start seeing the encopresis and the accidents, because just the new stool just leaks down through the walls, and then they may have accidents that they don't even feel it, right? And then, so the ideal is when the rectum is recovered, is that you see this wall, the muscular wall is just thick and healthy. The sphincter is working really well, is able to detect when there is some stool in the rectum, so they need to use the restroom, and they need to pass the stool, and also preventing any leaking from the other stool. So we also need to be aware of food selectivity. And for parents, it's very important that you talk to the pediatricians. I mean, we are in the obligation to screen for food sensitivity and also for restrictive diets, but we don't do it all the time. But this is a really common concern in children with autism, because as I said before, just the insistence of sameness and sensory issues, and they just may want to have certain food, and they just refuse to try new foods even. So in previous studies, they have found that even, the prevalence of food selectivity may be as high as almost 90%. So it's actually a pretty common issue. And and we're going back to the same problem. If you're not eating a healthy diet with enough fiber and enough fluids, so you may have some other secondary GI issues that may just be addressed by dietary changes. Also, if you have food selectivity, you may be placed at risk for nutritional deficiencies. And then also, you may also have some other medical conditions. As I said before, you may have GI issues. And then if you have GI issues, you may also have sleep issues, and you may have irritability. But unfortunately, the food selectivity is not an easy target to treat. So unusually, we need different type of disciplines to brainstorm and help the family. And we need to be sensitive. Sometimes, for typically developing children, the pediatrician sometimes say, like, you just offer what it is. It's not as easy for children on the spectrum. Sometimes if you don't offer what they want to eat, they may not eat or they may not drink. So it's a very difficult situation, not only for the child, but the whole family, just the daily life activities. And so usually when we talk about feeding therapy, we talk about an interdisciplinary group. We have one here in UC Davis. It is amazing. It's run by Dr. Stanfield. And we have a speech therapy there and different disciplines because, as I said before, it's not only the food selectivity, it's about the developmental issues. Is the child having any motor issues? Is the child able to chew and to swallow? What is the whole behavior? Is there any sensory sensitivities to the food textures or just to changes? Or any other behaviors, right? And sometimes it's also the whole relationship of the family with food and the relationship with the child. So sometimes it just takes several brains to brainstorm and also to build up strategies to be able, that is not a painful treatment for families. So with the dietary considerations, some children may be at risk of having diets that are low in protein. So imagine if you want just to eat French fries, you might not be eating a lot of proteins, right? And then the calcium and vitamin D as well. Sometimes that can even get worse if the family is trying to do some restrictive diets. Because they may not have enough calcium intake, and then you're going also to affect the bone growth, and then the iron as well. Well, it seems that is happening is that children sometimes may even have, when they're younger, they may even have difficulty gaining weight. They're just very restrictive diets. But as the time goes on, they may have more risk to becoming overweight or obese as they become older. So it's very important to be sensitive to these type of issues. With food reactions, so there is a wide range of food reactions. And so when we look at food reaction, you can have a structural intolerance. So you may have esophagitis, gastritis, you may have malabsorption that is causing that you're not able to tolerate certain food, right? There is also functional food intolerance. There is one that is toxic, and that happens to all of us. If we eat something that is contaminated, that has a bacteria, so you may present with a toxin effect, and then you may present with GI issues. But then there is also a non-toxic way of presenting with food intolerance. The most common one is non-immunological. And then for the food intolerance, like lactose intolerance. So you may present with a food intolerance that is just because you don't have the enzyme to process the lactose in milk, and then but that is not immunological. When we talk about immunological reactions, that's when we talk about food allergy, and it's not been proven that children with autism may present with higher rates of food allergy. So we have 4 different mechanisms to have food allergy. So the most severe one, thank you so much, is the one that is mediated by a substance that is called immunoglobulin A. And so what happens is like the person eats the food, let's think about the peanuts, and then the reaction is immediate. Like the immune system is like, we don't like that, but there's some other reactions that are more related, that are more delayed and are more related to different pathways, like the one that is activating the complement factors or hypersensitivity, but they're like less common within that range. It seems that the food allergies has been increasing over time for the whole population. So food allergies are actually quite common. They may present in infant and young children up to 8% of the population, and adults and adolescents up to 4% of the population. So if you think about it, children on the spectrum may present with food allergies, but the studies have been inconclusive. We have a most recent study that was done, I believe, last year, and it's the National Children's Survey. So they called parents and they asked certain questions, and they found an association with autism and food allergies and some other allergies. But so that what that means is that we might need to replicate some other studies to see if we find the same, because parents can say, yeah, my child has food allergies, but they may refer to food sensitivity. I mean, they're not supposed to, why they're supposed to know the difference? And then so more studies are needed to come out with different conclusions. And now we're going to listen to complementary and alternative treatments.
Thank you very much, Bibiana. That was a really wonderful review you did for us, and I do appreciate especially a lot of those resources that are there, both the papers in the literature as well as those toolkits from Autism Speaks that can be really helpful for helping with toilet training, with food selectivity, and then there are many that are even not within the scope of this talk, but just for sleep and other issues. It's a really good resource. So I'm going to switch gears a little bit, since we talked already about kind of workup and some medical treatments for common GI conditions, and talk about complementary alternative treatments, medications, kind of particularly focused in the GI symptom realm. Certainly this is not comprehensive, but I kind of want to highlight at least what we know, which you'll see at the end. We don't know much yet in terms of evidence for some of the popular kind of less mainstream treatments that are in the news and the media, or just kind of pretty common, and I'll go through those kind of systematically with you. But first, I just want to start with a little bit of definition about what we're calling CAM, or complementary alternative treatments. It actually means a lot of different things, but generally speaking, we're talking about the array of healthcare approaches that have history of use or origins outside of mainstream medicine. And when we say complementary, that generally means we're talking about an approach that's being used with conventional treatments, and alternative means something that is being used instead of or replacing a conventional treatment. Integrative medicine may be another label that you hear, and that's really about combining mainstream treatments as well as complementary and alternative approaches. And we certainly know this is very prevalent, especially in families with ASD, but certainly just in general. And so I wanted to start off with maybe just a framework for how we can think about approaching not just the use of CAM, but really any treatment that we use. These are some papers, one of the papers here from the Mind Institute, another one by Susan Levy, who's done a lot of work on CAM treatments in autism. And I think there's a really nice framework for thinking about how do we use the existing evidence, or when there isn't a lot of existing evidence, how we decide on treatment. So to start off, we're not always assuming that just because someone has a certain diagnosis, we're going to need a treatment, right? That's not generally how we approach use for very many medications, and that's kind of the same for complementary treatments too. We're really talking about impairment. Is the behavior getting in the way to a point where we need to intervene and try something different? Again, I guess getting back to what I was saying about a certain diagnosis doesn't automatically mean this type of treatment. We really want to talk, especially as, Bibiana mentioned about all these different sorts of comorbidities, what's the target behavior? What are we looking for to improve? And this seems pretty straightforward, but I have to say sometimes when we use certain treatments, we're not keeping in mind how we're going to measure improvement. How are we going to know if this intervention we've done, whether behavioral or biologic or anything else, is actually helping us? I mean, we need to be pretty cognizant of what we're doing, what we hope to achieve from the treatment, and how we're going to decide whether or not to continue. Always balancing risks and benefits, and then this is what I just mentioned. And so sometimes these 4 boxes is a good way of thinking about how we might make those decisions. Really balancing if something works or not based on the evidence of what we know versus what we know about safety profile. So if something's safe and we know it works, green light, that's something that we can recommend. We feel pretty comfortable using. It should help. However, if something that we know of is definitely unsafe and we know it doesn't work, we've got studies that show it doesn't, so something like chelation, for example, which is unsafe and also not effective, that'd be something, that we would probably discourage. What's a little bit harder are things in these boxes, particularly when we don't have very good data yet to help us. So if something we don't know if it works very well, but maybe there's at least a theory or a reason or mechanism why we think it might work, and we know that it's safe, that's something that maybe it's worth, as Bibiana mentioned, doing a trial and collecting data and seeing if behaviors improve. The same thing about if something we know is effective, but we're not sure if it's safe, maybe then there's more rationale for taking a little bit of risk in terms of trying a treatment. One of the very, very popular treatments approaches that families, particularly those with children who have autism, have pursued is looking at the gluten-free, casein-free diet. And so gluten is the protein in wheat, and casein is in milk. And the evidence for the GFCF diet is that it's probably safe, but we don't actually know if it's very effective. There have been a lot of different studies that have looked at this, including a meta-analysis of only 6 randomized controlled trials. So that's kind of your best evidence, best type of study that someone's done when they do a randomized controlled trial. So they have an intervention and then they have a placebo, and people don't know, it's blinded, so people don't know which one they're on or they're taking, and then you can really compare effects and try to ascertain whether or not the treatment made a difference. So again, this has been around for quite a while. There have only been about 6 studies that have really looked at this in the best way we can, and really found little evidence for benefit, at least when we look at it for ASD symptoms, and then also no change in GI symptoms. I mean, certainly there have been a few responders and other things like that, but when you look across the entire group of people treated as a whole, there not been enough improvement where it then makes sense that we can say there's great evidence or very good evidence or strong evidence that this is effective in treating ASD or GI symptoms. Bibiana already kind of covered this difficulty with the evidence we do have. So we don't have a lot of evidence, but even the evidence we do have is very difficult to kind of translate across studies because they've been done differently. There haven't been large sample size. There's a difference in what they're looking for in terms of what they consider improvement. They're not controlling for behavioral interventions that may also be in improving behaviors or medications people may be taking during the time of the intervention. As well as other pre-existing medical conditions or placebo effects. Certainly just because we're looking, sometimes people will report that things are getting better or that we're looking at things more, so we're actually working on them without knowing that this is having an effect. This was also a fairly recent study showing that the gluten-free, casein-free challenge, so this was actually a very difficult study to do. It was very well designed and very precise in terms of actually removing gluten and casein from the diets of children with ASD, and then reintroducing those, the gluten and casein to see if there was a change in symptoms. Because presumably, if there's a problem with this in children with autism, if you remove it and behaviors get better and then you bring it back in, you think the behavior should return. And in her study there, they didn't see any change when they reintroduced these, the gluten and the casein into the diet. And so, I mean, the risks involve nutritional deficiencies like protein, calcium, things like that, which can lead to bone loss, and it's a very difficult diet to do. If you're going to do it wholeheartedly or have it work, you really want to eliminate everything, and that's really difficult, especially for a child who may have restrictive diet, him or herself. It affects the family in terms of being able to travel or eat out. So there are real kind of risks and benefits to try to balance when we're looking at this type of intervention. The American Academy of Pediatrics did make a statement that they do not support the use of the gluten-free, casein-free diet. However, they do recommend that if families are going to pursue it, to seek guidance from a dietitian. I'm going to spend a little bit of time now talking about probiotics. So those are the good bacteria, the healthy bacteria that we see in the body that live in the gut. The evidence for probiotics is that they're probably safe, although we don't know if they are efficacious or not. There is very limited data that probiotics can improve behaviors in autism. And again, very few randomized controlled trials. We did a very small one here. I'll give you some of our results, and very few studies done. So no good evidence for it right now. Again, probiotics are the beneficial living organisms, generally bacteria, that modulate, that adjust the environment in the intestines. And some of this is based, as we go back to kind of theories that Bibiana laid out for us to try to think about, well, does it make sense for why this might even work? Is there a pathway for this to be effective? Or is this really something that, maybe is wasting our time? So the thought here behind the theoretical basis for it is that there is evidence for dysbiosis, or kind of a disruption in the bacterial composition in the gut of kids with autism. So there have been many studies, most of them from quite a long time ago, showing that the kind of healthy types of bacteria in the gut are decreased in children with autism, and that also just even the variety of the types of bacteria that you see it's lower in children who have autism. Again, going back to theories of why this may help or work, apart from just strictly affecting the GI system, probiotics may actually stimulate the immune system, and that can then affect the gut-brain axis. So that's the reason why we think it may affect behaviors as well as gut health itself. There is good evidence, unlike for autism, we do know that probiotics are effective in the use for other diseases. So irritable bowel syndrome, it's been proven to be efficacious. Necrotizing enterocolitis, or dead gut, so that's an infection that generally affects small premature babies, so it's being used in the neonatal intensive care units for little babies who are at risk for necrotizing enterocolitis, and it has benefit for protecting their gut. As well as antibiotic-related diarrhea. So after taking antibiotics, sometimes you destroy the existing bacteria that you need for your gut health. So taking probiotics can then reestablish that. So I'm just going to briefly tell you a little bit about the study that we did here looking at probiotics. It's a very small study. It was, again, and as with almost any dietary intervention, incredibly difficult to do, harder than we thought in terms of making sure kids would take the supplement and take enough of it and not have a problem with the flavor or the change. But this was a fairly rigorous study, even though it was very small. Young children, ages 2 to 11 with autism, who had very significant GI symptoms. So they had to have constipation, diarrhea, or both, and have this significantly impacting them for more days of the week than not, and actually impairing their function. So we only had 10 children enroll and 8 who finished. So again, very small. So when you're looking at the evidence, that's something that is a little bit weaker for studies when you're looking at them. And we looked at the difference between 2 types of interventions. So one was a prebiotic, which is kind of food for a probiotic for the bacteria, and this was actually a colostrum product. So it was a powder we made out of cow colostrum, and again, that could have some immune factors and other things, but it was essentially there to try to help keep the bacteria alive. And then the symbiotic, which is the probiotic, the colostrum with a particular strain of bacteria called Bifidobacterium infantis. So we had these 2 arms, so there was no placebo here. And we put each child on both treatments. So for 5 weeks, if they took the prebiotic alone, or the BCP, after a washout for the next 5 weeks, then they got the combination treatment. And so then we can compare the differences between the 2 different treatments for each individual. So again, we ended up with 8. One dropped out, and another child was discovered to have celiac disease after we started the intervention, so we disqualified that individual. You could see mostly white, non-Hispanic. Most of the kids in this group had diarrhea, 2 had constipation, and 1 had a mixed picture. Many of these kids presented with all those symptoms Bibiana was talking about. Pain associated with stooling, some with vomiting, a lot of them with gas and bloating. Almost all of them were picky eaters, and 2 of those 8 actually were quite low in terms of their weight percentiles, their BMI. And so what we saw, what these pictures kind of show us with the colors, is that after taking both treatments, so the combined treatment or just the prebiotic, we didn't see any changes to the bacteria that was present in their gut. So even though we were giving them more bifidobacterium, we didn't actually get that to colonize or stay. So we didn't change anything in terms of the bacterial composition, which is what we would hope for if you give an intervention. However, and then when you looked at differences in normal stools, and we used both a stool log as well as parents rating the consistency of the stool and the frequencies. You actually saw that it was for the combined treatment that you saw an increase in, well, for both treatments you saw an increase in normal stools, but that was only significant for the combined treatment there. So there was a little bit of improvement in their stool quality, more normal stools. And then for, these were things actually after the fact. We hadn't thought we were going to measure some of these things, but the parents ended up telling us that of the kids who were picky eaters, so again, most of them were picky to start with, a good number of them, actually, those that took the prebiotic only, the colostrum product, almost half of them had an increase in their desire or ability to kind of try novel foods. And that was less so in the combined product. And then looking at behaviors, we looked at behaviors many different ways. So we didn't see any differences in their everyday living skills as measured here with the adaptive skills. And we didn't see any differences in repetitive behavior. For some of these different behaviors and aberrant behaviors, we actually did see some improvements in total behavior, irritability, stereotypy, and hyperactivity for, again, the prebiotic alone. And for the symbiotic, we just saw improvements in lethargy. So, you know, I think it's a very small study. It doesn't help tell us a lot, but we also know that it was safe. We didn't have a lot of side effects with it. And it just goes to show that we need more well-done studies to be able to help provide more guidance towards whether or not this is something that would be recommended from a medical perspective or not. But it is safe, and it is plus or minus in terms of efficacy. I'm just also going to hit on fecal transplants or microbial transfer therapy, not because we know a lot about it, but it's been in the media quite a bit. And again, this is similar in terms of being a little more aggressive than just taking probiotics. So a fecal transplant means getting rid of someone's dysbiotic environment. So usually that means taking antibiotics to kind of wipe the whole gut clean of any bacteria, good or bad, that you might have, and then trying to get that environment reestablished with new bacteria. So that's the transplant part, getting someone else's gut bacteria mix into yours. So that's what it is. And safety is unknown, and we really don't know about the efficacy. We have no randomized controlled trials about this. And the people who have published it all had conflicts of interest, so you should take that with a grain of salt when you look at some of these things. Basically, the best I can find for evidence was an open label study, so everyone knew whether or not they were getting what they said they were getting, or a placebo. 18 children who had ASD, and they said they saw improvements in gastrointestinal as well as behavioral symptoms. That's it, though. I mean, we would like to see many more studies done more rigorously before we could kind of give any kind of endorsement for something like this. This was also interesting. You know, the FDA gave fecal transplants this fast track status. I think it was 2018. Because we're really trying to find more promising measures. They felt like this would be a promising intervention that might help individuals with autism specifically. But later that year, like a few months later, they actually issued a safety alert, not necessarily specifically to the autism population, but someone receiving a fecal transplant for another indication, not autism. Actually, 2 people died of infection. And so because of that, certainly if anyone is immunocompromised, they're not a good candidate for a fecal transplant. And that right now, you know, donors really need to be screened. The bacteria you're getting, you want to make sure is not a bad one that's going to cause a bad infection, that could cause these kind of unexpected consequences. Some of the side effects that have been reported in fecal transplants include infection, hyperactivity, tantrums, and worsening behavior, specifically with the wiping out of the gut with the vancomycin treatment. So taking antibiotics, certainly antibiotics are helpful, but they are not without side effects or risks as well. And we like to keep that in mind too. The last, I think, one I'm going to go through is just digestive enzymes, again, because that's been popular, and so there have been some clinical trials. Again, probably safe, but we don't know if it's efficacious or not. We just don't have enough evidence to be able to support benefit or not for it. And again, this is based on kind of the gut-brain axis theory, and then this unproven opiate receptor theory. So this idea that there are kids with autism have problems digesting different types of food products, like proteins and sugars. And if you have these proteins or sugars around, these, because of a gut that's not functioning well, these, presumably bad proteins and sugars are getting into the bloodstream where they shouldn't, and then binding to, receptors that are similar to opioids and otherwise. So none of this has been proven. It also is quite hard to kind of imagine that this is a kind of established or something that we can prove, despite how the popularity of this theory. So it's not one that really seems to make a lot of sense in terms of a mechanistic manner. And there are side effects: diarrhea, gassiness, bloating, so all the things you're trying to treat, probably, it can cause. Constipation, headache, and allergic reactions. Those were all that I was going to kind of review. Of course, there are so many others, and that is really kind of our intent in terms of thinking more about a general mechanism or framework for thinking about different interventions, as opposed to being able to try to say, which we can't definitively, about whether or not some of these interventions are ready for prime time, which it seems like they're not. But NIH has a great website for complementary and integrative health, and if you look up just a search for probiotics or for secretin or for anything that has a label, it will actually list for you different conditions, whether mental health related or physical or GI, that there have been studies done of particular things like fish oil, and it will tell you, like, fish oil has been probably efficacious for preventing cardiac disease, cardiovascular health outcomes, but no conclusive evidence for like ADHD or things like that. So that's a really great website. And our take-home points. Medical comorbidities, including GI symptoms, are highly prevalent in ASD. And oftentimes GI concerns are not adequately addressed in children and adolescents with ASD because of many reasons. So the identification and treatment of these comorbidities, particularly GI ones, have the ability to improve quality of life, and that's important and should be valued and shouldn't be kind of ignored just because someone might not be able to communicate effectively with us. Medical comorbidities may present as behavioral changes. They are treatable and should, get the appropriate attention. And then, providers really shouldn't assume that GI symptoms are just part of the autism. They should be evaluated in the same way, your pediatrician would think about a typically developing child who came in. And with that, we want to thank everyone very much for their time. We want to thank the SED for hosting us, and we will take questions. It's a small group, so what is your suggestion for adult autistics with GI problems? So, very good question. And I think it's not any different from what we're saying about the pediatric individuals with autism as well. I think, GI symptoms are prevalent. I think being able to seek medical advice and someone to really delve into a history and determine whether or not a workup is warranted is it should receive medical care in the same way any other condition should. I don't know if Bibiana wants to add.
So I agree. Sometimes care may present in a different ways, and especially if someone is not able to communicate that they have heartburn. So sometimes they may present with nighttime awakenings, or a cough, or wheezing in the middle of the night, or just food intolerance. So sometimes just trying this, a trial, I think most of these medications are pretty safe. Obviously with a with your provider, so making sure that maybe we don't need to do a further workup and then some other further tests. But I think it's worth it if someone is having a presentation that is very consistent with reflux.
Someone has a question about what to look for in an over-the-counter prebiotic or probiotic for children, like types of bacteria, for instance. So that's a really good question, and I would probably want to refer back to the literature. Like in terms of, in general, probiotics that have been studied in pediatric groups include lactobacillus, Culturelle is the trade name for the lactobacillus product, bifidobacterium that I showed you here, I think the trade name for that one might be Align or something like that. So those have actually been studied in children, period, not specifically in the subpopulation with autism, but at least we have some knowledge about safety and efficacy. Someone's looked, even though they probably are safe. I think one of the challenges with probiotics or anything that is an over-the-counter medicine, this goes for melatonin, it goes for other things, is because it's not a regulated substance by the FDA, you actually don't know what you're gonna get when you purchase something. I mean, so if there's any, it's hard to know that there's assurance of, like sometimes there are certificates that an agency can provide, but it's not the same as the FDA. So oftentimes, what happens is you just don't have the same concentration that it says it has on there, or it may not have any active ingredients at all, and we just don't know any way of knowing that besides trying it, and then you don't maybe see an effect. So that's the difficulty with a lot of the supplements that we use. I think the other difficulty and the problem with probiotics is that we still don't actually know what the right concentration is. So I can tell you from our study, certainly with the concentration we used wasn't enough to make a change in the gut bacteria. I mean, we saw some changes in stool and things, but it probably wasn't because the bacteria changed. It may have been because we had more fiber, or again, these other mechanisms that we haven't fully understood yet. But that is difficult too. It's not the same as we think about antibiotics, where we say this is how many milligrams. For kids, you say, per kilogram of weight. We don't know what the right dose is to be able to make any kind of changes. So the comment was about it's hard to know when you're taking a probiotic if it even makes it down into where it does. Right, it survives, and again, we don't know that, so it could be that stomach acid, it's not gonna survive going through that way. All of that is true. The other thing that is kind of related to that is, and makes it more complicated in choosing one, is it's probably not, every individual might have a different type of probiotic that would work best for them. So just because Bifido worked for like those kids in the study doesn't mean that for your neighbor, that's gonna be it. And so again, this is where we're getting into personalized medicine, and we don't have those answers yet. So if it's something that, is low risk and you're worth trying, it's worth trying and seeing if it makes any difference because that's of interest, sure, but I agree with you that going into it with a lot of expectation of change is probably not well supported, and expensive. Some of these supplements are really expensive.
Yeah, and I want to follow up on that. I mean, parents are really experts. I had a few cases when the child has like a mixture of bacteria and they have GI symptoms. They have distension, but the parents wanted to give it a try. So I usually recommend, if you're planning to try, just to try one type of bacteria. And then if it is well tolerated, if you want to do the mixed, that's totally fine, because there are like presentations when you have like mixed bacteria. So just to be aware of that. Has there been any research into possible connections between ASD and metabolic health and hyperinsulinemia?
So I can answer maybe a related question, and I might ask Robin if she has an answer too. So I know at least work that we've done here has shown relationships between maternal metabolic disease and increased risk for autism in that child, particularly during pregnancy. So there probably are potential relationships between ASD and metabolic health. I think what you showed us is also true in terms of individuals with autism are at higher risk for, and other neurodevelopmental disorders too, are at higher risk for obesity and weight gain. So that also increases your metabolic health risk. and then some of the medications that we use for individuals with neurodevelopmental disorders also increases that metabolic risk. But in terms of us having a very clear causal link, that doesn't exist right now, as far as I know.
Have there been any studies of low carbohydrate or ketogenic diets and possible effects on interactions with ASD? So as far as I know, the literature that I'm aware of is more towards people with seizures and intractable seizures, some other genomic conditions. I have a few patients with Turner syndrome and Kabuki syndrome specifically, that they're having some trials to see if these specific type of genomic conditions may also have a good response to a ketogenic diet, but I'm not aware of any.
Is that separate of the seizures?
It's,
Or no? Or is it for treatment of the seizures?
Yeah, it's for treatment of behavior.
Or behavior?
Yeah,
Okay.
so as far as I know, the literature that I know is more related to seizures.
And I think what I forgot to mention too, in addition to the NIH site, is clinicaltrials.gov. So any sort of intervention, whether it's complementary or mainstream or ketogenic diet, et cetera, if that's being done anywhere in the world, it's supposed to be registered with clinicaltrials.gov. And then also with that, hopefully, they're also monitoring for when results come out. Because so often we see all these studies and then they're never published and we don't know what happens. So they're trying to be keep researchers more accountable to actually disseminating the results, positive or negative.
Yeah, because sometimes we have tendency to read the studies that have positive results, but those studies that have negative results are also very important because that can guide your decisions.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.